And we're just waiting a minute or two to let people come in before we start the webinar.
Great.
Yes, please.
Number slowly going up.
You can see somewhere. Oh, yeah.
Okay, stagnating. Good. I think we can start. So good evening to everybody and welcome to this EANS spine section webinar. We're having every first Wednesday a month. And again, today we're having the same format. We're having one presenter I'm going to introduce later and having a presentation on a relevant, very relevant topic and some discussion afterwards. So for the discussion, as always, the housekeeping announcement, please type your question in the Q&A box and I'm going to moderate those questions and then ask them to the presenter. We're going to discuss all the questions the majority of questions you type in. Now, the topic we picked for today is, I would say, quite a controversial topic. It's odontoid fractions in the elderly population. We know there's a lot of treatment variations throughout Europe, with some of departments or some countries being quite aggressive in the treatment of odontoid type 2 fractures in the elderly, going for very early surgery, while other countries are more conservative, going for an immobilization in the collar, or not even without collar, just aiming for a dense pseudoarthrosis is meant to be sufficient for the elderly population. We know that fusion is not good if we go for anterior surgery. It's quite sure, but we're still not quite sure what the adequate way of treatment for those patients is, of the elderly or old patient with an odontoid type 2 fracture. And therefore, I'm very happy that we have a dedicated speaker on this topic today. We have Jeroen Huybrechts from Leiden University in the Netherlands, and he's experienced from scientific and clinical side experience in the treatment of those elderly patients with odontoid type 2 fractures. He is author of meta-analysis tackling this question, and he's the principal investigator of a study, a randomized trial comparing conservative treatment versus surgical treatment in odontoid fractures of the elderly population. And I'm very happy to have him here as a presenter tonight. Now, the study results he's going to present in his talk tonight are unpublished results so far. They are under review in a, as I was told, high impact journal. So please, for this webinar, don't take any pictures of the figures which are shown, because this could get them into trouble with the editor of this journal. So please don't take pictures of those figures. You will see it in a publication quite soon, hopefully. So now it's your turn. Thanks for being here. Thanks for giving a presentation on these odontoid fractures in the elderly. I'm very much looking forward to your presentation. Thank you.
Thank you, Florian. I'll share my screen. Hope you can see this.
Yeah, we can see it.
I've been, as Florian already discussed, I've been looking into this topic for over 10 years now as part of my PhD research. So by now, I think I know a thing or two about these fractures and the controversies. So I'm happy to share some of my ideas and my insights in the topic. We'll start with an overview, then go on to the recent systematic review, the recent meta-analysis we published last year. And then we finish off with the results of the international study that we've been conducting and which you may have heard about already. Odontoid fractures, they're the most common cervical spine fractures in the elderly, and they often result from a minor hyperflexion or hyperextension injury. And they've been associated with osteoporosis as well. They are increasingly relevant to clinical practice due to aging of the population, and also the incidence and the healthcare burden that are associated with these injuries is expected to further increase as a result. And interestingly, and as Florian already introduced, the optimal treatment is still very controversial and much debated. Historically, the focus was on fracture union. So if there was a union, the treatment was considered a success. And if there was a non-union, the treatment was considered a failure. And none of the researchers bothered asking the patients how they felt about it, at least not when we look back decades. But luckily, that has changed over the last decades, with now a focus much more on a favorable clinical outcome than just looking at radiological results. But still, we see that treatment is often based on local treatment culture, on how the surgeon was trained, on the experience of the surgeon, with advocates, both strong advocates of a surgical treatment and both advocates of a very conservative treatment. And it leads to considerable national and international practice variation, which in turn is a sign of low value care. And I think something we should change if we have the means to do so. If we look at treatment, I assume this is all familiar to you, but just very briefly, if you look at the treatment options, you can go for surgery in the form of anterior odontoid screw fixation, or a posterior, various forms of posterior C1, C2 fusion, or you can go for a conservative treatment, and that being a non-rigid immobilization in the form of a cervical collar, or a rigid form of immobilization in the form of a halo vest. More and more, we see nowadays C1, C2 fusions and cervical collars for the elderly, but still a lot of centers use all four of these techniques. Some numbers then. In the United States, in the first decade of this century, we've seen a 5-fold increase in the in-hospital charges for treating these patients, to over $1.5 billion. So it's really high. I don't know the numbers of the last decade, but it's probably went up from there, with surgical treatment rates in the US doubling to 86%, and operative treatments costing twice as much as conservative treatments. So both the incidence is going up because of the aging of the population, and people are treating more surgically, which is a more expensive treatment, both adding up to increased costs, which is of course, if the patient benefits, then of course that's a good idea. But if that's not so sure, I think we should think again. And in Europe, we interestingly we see not that trend towards more surgical treatments, rather the opposite. But it's really interesting to see a different approach to this on both sides of the Atlantic. So what to do? What should we do? Should we operate, or should we treat them conservatively initially? We did a systematic review on the topic, one in 2013, and we recently published an update of that last year. We looked in 7 medical databases in which we considered clinical outcome to be the primary outcome, and fracture union and stability the secondary outcomes. We calculated the pool point estimates and confidence intervals, and we did a multivariable analysis to correct for baseline differences when they were sufficiently reported. Here you see the flow chart with 17 patient studies from the previous review, and quite a lot has been published in the last decade. And we were able finally to include 41 studies in the meta-analysis. Interestingly, only one of those studies we could classify as a cohort study, in the sense that it corrected for baseline differences with the multivariable analysis, and all other 40 we had to consider they were just case series. In fact, the data were very heterogeneous, with typically small patient groups. Outcome assessment was done at different time points, and this is important. We'll get back to that later. But it was not uncommon to compare patients at various points throughout treatment. And you can imagine, if you compare the outcome for one patient at 12 weeks to another patient or a patient group at 52 weeks, of course, you're going to see differences that are not necessarily the result of the treatment, but rather the moment at which you assess these outcomes. And also, typically, there was no correction for confounding variables. So we were only able to do a meta-analysis for the union and stability. and then only to correct for age and fracture type, because those were the only covariates that were sufficiently reported. If you look at clinical outcome, the neck disability index, the visual analog scale for pain, and the Smiley-Webster scale were the ones that were most commonly used, and we didn't find clinically relevant differences between any of those between the treatments. If you look at fracture union, on the other hand, you see that the pooled point estimate there's a significantly higher union rate for surgical patients. So it's over 70 in the surgical group and over 40 in the conservative group. Then if you look at fracture stability, we see that it's about 80% in the surgical group and 70% in the conservative group, which is not significantly different. But again, data was substantially heterogeneous, and that limited the possibilities for analysis and also the strength of the recommendations we can draw from these results. We did see higher union rates after surgery, but selection mechanisms might at least partially explain that difference. So for instance, surgery for relatively healthy patients, and as I said, outcome assessment at different time points, which might very well have influenced these outcomes. So we conclude that the results need to be confirmed in well-designed comparative studies in order not to compare oranges to apples. And being a Dutchman, I like to compare oranges to oranges. So that's where we come in with the Innovate trial. We did it together with a lot of European colleagues. We didn't do it alone, but we aimed to prospectively compare the effects of surgery with initial conservative treatment on clinical outcome, fracture union, and fracture stability at 52 weeks. We did an international perspective comparative study in 15 centers, 8 European countries. Here you see a list of the participating centers and the participating, the local principal investigators. You might recognize some of the names. Some of them, for some of you, might even be listening in. I cannot see at the moment. We've been including patients for about 2 years, and then we followed up also the last patients for 2 years. So that's why we do have final results at this point after a 2-year follow-up. The patient selection, the patients were all aged 55 years and older with acute type 2 or 3 odontoid fractures, diagnosed using CT scans. There was no previous treatment for the fracture, and there was no language barrier or no cognitive impairment, in the sense that we wanted to be able to ask the patients how they were doing, how they were feeling, and if they felt they had recovered. Treatment was in accordance to local usual care, so there was no randomization. It was all observational. So a shared decision was made by the attending surgeon and the patient, and all centers were able to facilitate both treatment modalities. We scheduled 5 follow-up moments between 6 and 104 weeks, at which we asked the patients to complete questionnaires at home and at all these follow-up moments, and they were sent back to Leiden for evaluation. And then follow-up moments were scheduled clinically as well. And those visits could be terminated, could be ended earlier by the treating surgeon if the patient was deemed to have achieved complete clinical recovery or nearly complete clinical recovery in combination with fracture union or fracture stability. The primary outcomes were the neck disability index improvement, the fracture union on CT scans, and fracture stability on dynamic X-rays, in which we also considered stability to be present in the case of fracture union. Secondary outcomes were the visual analog scale for neck pain, patient perceived recovery of symptoms, and patient perceived recovery of neck pain, and then the EQ-5D. We looked at complications in terms of secondary neurological deficits, secondary treatment, mortality at 52 and 104 weeks. We did subgroup analysis for patients aged 55 to 80, over 80, and then for type 2 fractures separately. As Florian already mentioned, most discussion is usually about focuses on type 2 fractures. So we did a subgroup analysis for that, and there was, and then for displaced fractures over 2 millimeters. And a post hoc analysis as well, in which we compared odontoid screw fixation to C1, C2 fusion and a collar to Halovest treatment. We did look at NDI improvement between baseline and 52 weeks, in which a lower score indicated clinical improvement. So it's a degree of disability between 0 and 50. The higher the score, the more disabled the patient is. So if the patient has a decrease compared to baseline, it's a clinically improvement, in which we consider a minimally clinically important difference of 7.5. Then we did correct for baseline differences between the groups in terms of age, gender, fracture type, fracture displacement, other C1, C2 fractures, degree of osteoporosis in C2, and degree of degeneration in the C0 to C2 facet joints. We did similar analysis for the secondary outcomes and the subgroups. And we also analyzed the association between NDI improvement and union status. So does indeed the patient benefit from achieving fracture union, or is there no clinical link? Missing data we addressed with multiple imputations. We did the primary analysis with the multiply imputed data set, and the sensitivity analysis with the original non-imputed data set. And as we already mentioned, the following is still under review, so please do not distribute this so far. We'll get back to that later. This is the flow chart. We were able to include 279 patients. 46 were included in the surgical group, of which about half of them was treated with C1, C2 fusion, about 20% with anterior odontoid screw fixation. 2 patients withdrew from the study, so we're able to analyze 144 of the surgical patients. Then in the conservative group, there were 133 patients, of which the vast majority was treated with cervical collar, but also some HaloVest were applied. 1 patient withdrew from the conservative arm, and then we analyzed 132 of those patients. Baseline characteristics here for each treatment. So for the surgical and the conservative patients, we see that they were relatively, the most baseline characteristics were comparable. Not for 2 of those. We looked at, if you look at type 2 fractures, you see that the the percentage of patients with type 2 fractures is higher in the surgical group than in the conservative group. And also the degree of displaced fractures is higher in the surgical group than in the conservative group. But again, this was corrected for in the multivariable analysis, so that's why what we did take into account. This is one of the most interesting slides, I guess. These are the primary outcomes at 52 weeks, in which you see here the NDI improvement. That's for the surgical patients -11, and for the conservative patients it's -14. So that difference in the multivariable analysis is neither statistically significant nor is it clinically relevant. So clinically, there is no difference at 52 weeks between these treatments. For union, we see that 86% of the surgical patients had achieved union and 78% of the conservative patients, and especially this number, you might think, you might feel that it is high, but again, remember that we're looking at 52 weeks, which is much later than than most studies that have been previously been published. And if you look at the multivariable analysis, we see that that this is almost it's not a significant difference. It's numerically favoring surgery. It's almost a significant difference, but it's numerically favoring surgery, but there's at least not a huge difference between the 2 groups. Stability, the difference is even smaller, and we see that almost all patients achieve fracture stability at 52 weeks. For the secondary outcomes, we see more or less the same results. So if you look at the visual analog scale for neck pain at 52 weeks, there is no difference between the groups. The same is true for the patient perceived recovery of symptoms and neck pain at 52 weeks. So there is no significant difference, but it's interesting to see that the percentage of patients that reports that they have completely recovered or nearly completely recovered was low in both groups. So not even half of the patients at 52 weeks feel that they have completely or nearly completely recovered. So that's something to keep in mind and be a bit humble about, I guess. And for the EQ5D, we saw only for the FOS health at baseline. So the surgical patients rated their health a bit better than the conservative patients. Statistically significant, but whether it's clinically relevant is an entirely different question. Then if you look at the association, also an interesting slide, between NDI improvement and union, we see no difference either. So the there's no clinical difference for patients with union and non-union. If you look at the total group, we see that patients with union have a mean improvement of -13 and in the non-union group of -12. And then you might think, well, if I've operated on them, then that makes sense because I've stabilized the fracture. But also if you look at conservative patients, if you split them out by treatment, then you don't see a difference between the two groups. If you plot outcome over time, I think this is also it provides some insight. You see here on the y-axis, you see the various follow-up moments, and sorry, on the x-axis, and on the y-axis you see the various outcomes. So here for the neck disability index, you see that it's slowly going down, so representing a clinical improvement up until about 26 weeks, and then it flattens out more or less. And we've been looking at 52 weeks, remember, for the primary outcome. And then you see here the surgical patients are plotted in blue, and the conservative patients, I guess it's orange. And there's no significant difference. The bars here represent the confidence intervals. If you look at union, then you see the same difference. So it's numerically favoring surgical treatment. We didn't find the difference in the multivariable analysis. But again, remember that for the conservative patients in the meta-analysis of last year, we found about 40% had achieved fracture union. And that's not strange if you look at a very early point in time. But if you look later, you see that it keeps going up. And if you look at 52 weeks, the percentage are much more higher than I think that is something we would recognize from clinical practice, because I think typically we do not follow up these patients for 52 weeks, but we see that quite a lot of them achieve union after all. For stability, yeah, almost everyone achieves fracture stability. So that's something to be, I think, happy with. For the neck pain, we don't see a difference. And the same is true for if you plot the other secondary outcomes. There are no relevant differences there either. Complications, also interesting, we didn't find a single case of a secondary neurological deficit. So we've been told, I think, many times that to be cautious of fracture displacement, of the potential consequences of myelopathy, of sudden death. We didn't find a single cases. I'm not aware of any cases in literature as well. So it's something to keep in mind. We didn't find it. Not surprisingly, secondary treatment was less common after surgical treatment. 9 surgical patients received secondary treatment, of which 3 were over 80, and 23 conservative patients received secondary treatment, of which 7 were over 80 years. There were various reasons for these secondary treatments, usually prolonged instability or prolonged non-union. Persistent symptoms were only mentioned in 4 cases, so it was usually radiological results that led to secondary treatments. The time to treatment was skewed, but it was not statistically significant. There was not a statistical difference. Mortality at 52 weeks and at 104 weeks did not differ either. So if we look at 52 weeks, we saw that 12 surgical patients and 15 conservative patients died. And if we look at 104 weeks, 14 surgical patients and 18 conservative patients died. It's of course an elderly population. This is death by any cause. So it's not surprising that they die, and at least that we didn't see a relevant difference between the groups. The time to death was skewed either as well, but it was not statistically significant. There was not a statistical difference. If we look at the subgroup analysis, so if we look at the neck disability index improvement between baseline and 52 weeks for the 4 subgroups, then we see that there is a statistically significant better result for the conservative patients, in the sense that they have a -17 mean improvement in the neck disability index versus -11 in the surgical group. That difference is statistically significant, but we do not consider it to be clinically relevant. The other ones, there is no difference there. If you look at union at 52 weeks, we see for type 2 fractures that 84% of the patients achieved fracture union in the surgical group and 65 in the conservative group, that difference was statistically significant in the union variable analysis, but not if you, after correction for confounding variables. And then if you look at stability, we did not see a difference at all, with almost all patients achieving stability at 52 weeks. If you look at the subtype analysis, so if you compare odontoid screw fixation to C1, C2 fusion, then of course we didn't power to find a difference here, but this is just an exploratory analysis. But we didn't find huge differences between odontoid screw fixation or C1, C2 fusion, and neither did we find it for collar versus halo vests. But of course, it's relatively small groups, but it provides some insight. I think we're looking at the most extensive comparison of surgical and conservative treatments that we have available so far, and also the first to properly do a multivariable analysis to adjust for patient and fracture characteristics to make the groups as comparable as possible. The outcomes did not differ for the NDI improvement, union, and stability, nor for any of the secondary outcomes. The NDI improvement did not differ between patients with union and non-union, so that suggests that there's no clear link between the two, and that I think a favorable clinical outcome should be the goal of treatment and not union per se. We did not find cases of secondary neurological deficit, so historical fears for undertreatment are unjustified, I guess. There was no difference in mortality between the treatments, and also in subgroup analysis, we did not find relevant differences. Of course, this study has limitations. It's not perfect. This was, of course, a non-randomized study, so there is still, of course, a possibility for residual confounding. We had quite some missing data points, so of course, I guess it's a result of looking at these kinds of patients, of elderly patients, a multi-center international setup. So we've been discussing extensively with the statistical department on how to handle this, and we decided to go for multiple imputations instead of the last observation carried forward approach that is sometimes used in other studies, in which you let's say if you look at if the last moment you have available is at 12 weeks, and then you lost, and it's a non-union, and you then lose the patient in follow-up, then you extract that until 52 weeks and analyze the patient in a non-union group. And that is, of course, neglecting the possibility of a more favorable outcome between the last follow-up moment and 52 weeks. And it underestimates the treatment effect at 52 weeks, but it rather reflects outcome at the last available follow-up, as did the studies that we included in the meta-analysis. And the final point, I think, is relevant, that we did not do a standardized assessment for baseline health status, so no ASA scores, no injury severity scores, and that if we could go back, I would for sure add those. But if this was influential, I think it probably favored the surgical patients, as multiple studies have shown that those patients are typically a bit healthier than the conservative ones. But we didn't, it's a bit speculatory. I think we can conclude that initial treatment, conservative treatment, is justified, reserving surgery as a secondary treatment in relatively rare cases of persistent symptomatic non-union, and that a favorable clinical outcome should be the aim of treatment. Some other studies that are expected, I'm not sure about the status of these studies, but I'm curious to find out the results. This is a randomized trial. I'm from Sweden. I think it includes about 40 or 50 patients. This is a study from North America by the same group that published the AO cohort about 10 years ago, in which they compare C1, C2 fusion versus bracing alone. So that suggests that they are also applying post-operative bracing, but at least it's also a randomized trial. And then there's the Dent trial in the UK, in which they compare collar treatment to, well, practically no collar treatment, so no treatment. So I'm really curious to find out the results of that study as well. It's still including patients, I believe. So thanks to all participating colleagues and all the patients, of course, but especially the colleagues who have made this European project, I think, a success. Thanks to Wilco Jacobs, the project epidemiologist who has been involved since the start, and he's been really a great help, and also the Department of Statistics from the Leiden University Medical Center for their help in the analysis. So I think that's what I wanted to share with you. So maybe we can go on to some questions.
Great, thank you so very much. Can you, sorry, hi.
And share.
Great talk. Hi. Thank you so very much. A great talk, as always, from your group. Excellent research. Thank you for that. So we have 3 questions. They're basically the same from the chat room. They all want to know how long did you do immobilization with the collar or the halo? And one question was, if they did surgery, did they also have immobilization afterwards? If so, for how long?
Yeah, so that's a fair point, of course, and that was not standardized. So that differed depending on the center. So I know for most centers it was a 3-month collar treatment or immobilization, but it was not standardized. So that varied, and it might have been influenced on might have influenced the findings. Yeah,
Well,
but
thank
typically
you.
3 months.
Typically 3 months. Also after surgery as well.
Typically not after surgery, but again,
Right.
if the local usual care was post-operative bracing, I believe there was no center that did it, but we didn't prohibit it, but usually not.
Thank you. So we have one more question from Dr. Stefan Motov. Would you recommend MRI for ligament assessment or only flexion extension and X-ray?
Sorry, I didn't hear it. Can you repeat it, please?
Yes. How would you assess for instability? Would you use an MRI to assess the ligaments or only use flexion extension X-rays?
Yeah, you mean throughout follow-up?
Right.
Or at baseline? Yeah, at follow-up, I think dynamic X-ray is sufficient. So if you are interested in radiological outcome, then go for a CT scan. If you see a union, then of course that's done. Then you know it's stable. And if you're in doubt, then and you see a non-union, then go for dynamic X-ray. We use the cutoff of 2 millimeters to classify stable and unstable. But I don't see a necessity for regular MRIs.
Right. So, but primarily you would look for the clinical outcome, right?
Exactly.
So
Yeah.
Okay.
Yeah. So
it
for
wouldn't.
this, sorry.
It wouldn't change how you would manage these patients if you was doing clinically okay and still unstable. You would wait further.
Yeah. So we see that almost all patients they achieve stability, and especially the ones that have an asymptomatic non-union. I would say just wait and don't just accept it. Because we didn't see any problems of that. That's what I usually do now in clinical practice. So you sometimes see patients with non-union, and I'm still have to encounter the first patient that has complaints from it. Of course, there ones with symptomatic instability, and then treat those patients with surgery in the second.
That was also the last question from the audience. Did this change how you would manage these patients? Do you do now always or most of the time conservative and then surgery, or?
Yeah, I think so, because so there's quite some variation, as I said. So some centers now, as also from the start of this study. So for instance, in Utrecht in the Netherlands, everybody is treated conservatively first, and they've been doing it for years. And for instance, in Munich, there was also part of the study that almost all patients get a primary surgical treatment. And then most centers like mine, they follow at least historically a more fracture-based approach. So if you consider the fracture stable or displaced, and the patient is relatively healthy, then go for surgery and go for conservative treatments if it's really if it's an older patient with a non-displaced fracture. But now I think we've seen that a gradual change towards a more conservative approach, and then reserve surgery for as a secondary treatment if it fails.
Okay. And one of the questions were if you have an age limit to perform surgery.
No.
No, very good. One question for me then, where I was a part of the Munich group, and we did do mostly surgery, but we did also see a few failed conservative treatments with regard to wound healing disorder and, you know, problems with the skin. So did you see that
with the skin?
sort
Sorry,
of, with the skin, yes, with the skin, with the collar.
You mean the pressure source?
Exactly. Yes.
Yeah. So yeah, we didn't systematically report those. But it's sometimes, of course, from halo or from colors, you get some issues as well. But we didn't systematically look into those. No.
Okay.
Is that something you find a problem in clinical practice if you apply color treatment?
Yes, if you know, semi-rigid or rigid collar treatment, we've had a few, or not so, not a low number of patients coming back with skin problems, and this was primarily why we decided to go to surgery where it was preferable in our hands at least. But again, these results you have shown now need to be discussed, and probably this will be a change in practice all over Europe, I would think.
I hope so.
Yeah. Okay, thank you from my side. Florian, do you have anything to add?
Yeah, I have some questions. Thank you for this excellent presentation, this very interesting data you shared. Well, this is as Ihab said, I'm worked for a long time in Munich as well, and in Germany and many centers we were quite aggressive with this old population, not the elderly, but the old population with odontoid type 2 fractures, and going for primary surgery with the belief that if you put those patients in a collar, you can see how they decline. They don't swallow adequately, they don't eat, they don't drink.
Yeah.
This was our experience, and that we experienced some of those really relevant pressure sores. So therefore, we many years ago we had this publication looking at very old population and making our arguments for quick surgery in those patients to get them out of a collar and get them with eggs quite early. Now this is yours is in contrast, but I was a bit surprised when looking at the age range you looked at, 55 to 80. If you tell the 55-year-old now you're in the same age group as the 82-year-old, he will be quite unhappy.
Yeah.
This is a different population, and that potentially the good conservative treatment results in this population, which is probably skewed towards the younger patient, influence the conservative results and make the conservative results probably a bit more favorable than they would be in the very old group. And how large was your very old group above 80, which you looked at in the subgroup analysis?
Well, to give you a number, I have to get back to I don't know it by heart. Let me look it up. So the group from above 80 was in the surgical group 63 and in the conservative group 60.
So it's a relevant proportion of your whole groups.
Yeah, so it might have influenced, and of course an age cutoff is always a bit arbitrarily, but especially we wanted to look at the octogenarians separately, and that's why the rest ended up in the 55 to 80 group. But I agree that might have influenced, might have been of influence. And if I may get back to what you said about the pressure source for the have you tried, because that's what we do now in our region, that we let people take the collar off if they are in bed, because you let them wear it for 24/7 or not?
We had them wear it for 24/7. Yeah, that's true. And it's probably as other countries show, probably in the large group of those patients, we don't even need the collar, as they do well, as you showed as well, that there's no secondary neurological deficit, no secondary neurological problems. Yeah. And in this, you had this 19% crossover from the conservative arm to the surgical arm. How are those patients analyzed? Is this as an initial intention to treat analysis, or finally as treated?
Fair point. So we are really comparing the strategies. So they have been analyzed in the conservative group. So we're comparing surgical treatment to initial conservative treatment with the potential of a secondary treatment. Secondary surgical treatment. Do you follow what I'm saying?
Yeah, so you could get to the conclusion a initial conservative treatment is justified.
Exactly. I'm not saying you should never operate these patients, but I don't think there's a necessity to primarily do it.
And did you look at it as in a as treated fashion?
Or
not yet.
No, not yet. No,
Okay.
no. I really intention to treat.
One question from my side. So the patients between 55 and 67, so they were out of work for 3 months, or how would you manage those? Would you just recommend for them to stay at home, or are they able to go back to work after a short period?
I think that depends on the patient. And what I don't personally, I don't prohibit them to go to work, but I guess most people stay at home, at least don't do any physical heavy physical labor. So I think most people will at least not work as they normally do, but it's not something that we dogmatically say they cannot. How is that in your center?
Also, not they should not work, for at least until the first follow-up we have. But most of them don't want to work actually after an accident, so it's not an issue. Thank you. So let's see if we have any more questions from the chat box. Any data about secondary hardware failure in the non-union patients with screw pull-out, loosening, or breakage of the rod?
That would be interesting, but we didn't gather that separately. No.
Okay, thank you. Magst du abschließen? Close, Florian? Okay. Well,
you want to continue? Yeah.
We're already through all the questions, so I think we're also very good in time. If you would you like to wrap it up?
Okay, yes. So I think that this was a very excellent, nice presentation from this new data, these new data, and I'm happy to see this in a printed way and keep my fingers crossed that get it in the journal. Now we saw new insights that a potential conservative treatment in those elderly odontoid fractures seems to be justified, and I think what is important is to show as well as that there is no real risk for a neurological decline in those patients which are let's say awake and aware of their situation. Thanks to all the participants. We had over 100 participants. Thanks for your presence and for bringing in your questions and having a lively discussion afterwards. Thank you, Jeroen, for this nice presentation. Thanks, Ehab, for this moderation as well. And I would be very happy to see you again in the next first Wednesday of April. I don't remember the exact date, where we should have a presentation on the use of spinal robotics and the experience with spinal robotics. So enjoy your evening, have a good time, and see you for the next webinar of the EANS Spine section. Thanks a lot. Bye-bye.
Bye-bye.